Most of you probably saw my topic. My topic is all on teeth, the push for saving teeth. I I am one of my favorite things to do is treat a worn dentition case. Worn dentition cases for me, I love because of the challenge, the ability to truly change somebody's life by implementing everything we teach at the Dawson Academy. And my goal here is to go over concepts that I've used from Dawson and other concepts from other research I've learned into treating a worn dentition case. Basically, we're going to look at implants versus teeth. Pretty straightforward. We're just going to look in the differences between the two. I love placing implants. Maybe my favorite thing to do, right behind restoring a worn dentition, but there are limitations. Then we're going into the vertical challenge. We're going to look into what's involved with opening the vertical on a patient and where we need to start. We're going to look at treatment planning and sequencing, functionally driven aesthetics, and then some closing thoughts. And nested in all of this is going to be a case that I'm going to go over where I think there's some good teaching points that hopefully will help you guys out. Mentors, it's a very important note. I think some of you are going through the curriculum. If not, I would highly encourage it. I went through the curriculum. I saw Pete Dawson speak in 2004 with Glenn DuPont, and then 2005, John Cranham joined the team. And then I was an associate. And then when I started my own practice in 2010, I was like, I'm going to finish all of this. So I went through it pretty fast from 2011 to 2013, which was this photo here, where I got my Scholar Award, and it was life-changing. And this is the last time I saw Pete Dawson. It was the last year he was alive, with another titan in the industry, Jerry Sheesh. Jerry Sheesh is wonderful. He's from the LSU. He's a professor at LSU, and really, what a master on full mouth rehabilitations. And of course, Pete Dawson, who's just an icon who just created everything we do. Just so you guys know a little bit about me, I'm Indian. I'm an Indian Catholic, which sometimes confuses people. It's like they ran into a Muslim redneck. But this is a picture of a church that we attend. And I was always pushed to be a medical doctor. That's the Indian way, at least my generation. So I think my parents were a little bit disappointed that I became a dentist, but you know what? It has been incredible. I love this career so much. My favorite dental procedure, one of the things I love to do is implants, like I'm showing you here. This is a case. It was staged between an immediate for tooth number 3, graft, and then implant for number 4, and then the final crowns. And one of my favorite things to do, if I can, is immediate posterior implants. A, because of the implant, placing implants. B, I don't have the stress of working with implants in the anterior zone, which is really stressful. And it's just so rewarding to do this. Now, implants versus teeth. This is a patient that came to our practice years ago. Thought he had no hope and he would have to have all his teeth taken out. And, we really pushed to save his teeth. And it was one of the worn dentition cases I'm the most proud of. But when we're looking at implants versus teeth, are implants the best option? As much as I love to place implants, I have to be realistic. And is it the best option when we're treating these patients? So when we're looking at teeth versus implants, there's a couple of things we need to note. I was very fortunate to see Carl Misch teach. I went through his curriculum when I started my implant career about over 12 years ago now. And his textbook was, really influential, almost as influential as Pete's book. And in his book, he talked about teeth. We know teeth have a PDL around the tooth that reduces stress transmitted to the bone. When you're looking at implants, though, it doesn't have that shock absorber. And the force, when an occlusal force happens, the energy that's imparted to the rest of the tissues is much higher intensity. It's a much higher intensity force, and the functional bite force is 4 times higher. So from a force standpoint, something that's so big with us at Dawson, you know, implants compared to teeth, I mean, there's a huge advantage with keeping teeth. One of the ways to think about it, one of the analogies I like is when you're thinking about teeth versus implants, is implants, an implant restoration impacts like a hammer, and a teeth impacts like a mallet. Okay, so where there's much more spreading of the shock and the force, and it's just more gentler impact versus an implant, which is just like a hammer. I love that analogy. I think it's a great way to differentiate between the two. This is a patient when earlier in my implant career, I placed an implant, a pretty large implant for tooth number 19. You can see tooth number 20 was chipped and broken. We restored it, but kept chipping and breaking it. Uh, and then what happened was about 3 years later, it started getting bone loss. This bone loss around the implant. You can see tooth number 20 still hanging on, broken again. He didn't want to do a crown. And so that was just putting more force on number 19. And this implant failed. It came out. I didn't have to use any local. Uh, and this is a patient who has wear and chipped and worn teeth, multiple areas. He didn't want to do full mouth rehab. This implant, even though I took this crown out of occlusion, it couldn't withstand the occlusal forces, and this is what happened. Teeth, as even though the Dawson caliber, I'm going to talk about occlusal schemes. Teeth can tolerate interferences, contacts on inclines, even though that's not ideal. Implants, though, really cannot. And implants, that force has to be directed right down the long axis of the implant. Any interferences, contacts on inclines can be really detrimental to that implant. One key thing too when we're looking at teeth is looking at the feedback loop between when we chew to our brain. Okay, and that feedback loop is so important. And this is one of the diagrams from Pete's textbook. That feedback loop helps us to control the force we're exerting when we chew. Again, when you have implants, that feedback loop is gone. Okay, and so especially if we dentulate somebody, an all next patient, obviously there's situations where we have to entertain that, and that is a great treatment option. We do that here, but it's when we lose that feedback loop, it makes a big difference in terms of force. Now, one of the other things too, this is a great study worth for you guys to look at. It was a study where they looked at 40 patients with periodontitis versus 40 patients with periimplantitis. And what they were looking at was the size of the inflammatory infiltrate into the surrounding tissues. And when they looked at these two groups of patients, the amount of inflammatory infiltrate into the connective tissue was significantly larger with periimplantitis versus periodontitis. So when we're talking about the periodontal tissues and any inflammation or disease that's happening, the disease can be a lot more magnified and more pronounced with implants. Big difference, almost 3 times the difference. Now, I'm talking people that are doing implants. I just, I place implants today. I love placing implants. I'm not trying to say implants are bad because I think there's a lot of times when they are warranted. For example, a patient with high caries risk, people who are negligent with their oral hygiene, and the risk is high, then implants, especially if the tooth is non-restorable, can be a great option. These are 2 different examples of patients who came through our practice. And what are the risk factors, considerations for implant replacement versus saving teeth? Now, patient on the left, I mean, really bad, caries control, especially in the front. The caries wasn't as bad with the molars, but his front teeth were essentially failed on the lower arch. Patient on the right, you can see here, he's not a caries prone person, but just really severe wear, like almost into the pulp on most of his teeth. Now, what are the risk factors? We have to look at caries risk. We have to look at periodontal health. We look at the crown root to ratio and tissue biotype and the overall restorative prognosis. The treatment for these two patients is completely different. Patient on the left, we took out those teeth. We kept his molars. He didn't want to do crowns. We took out the wisdom teeth actually, but we kept the remaining molars. I did a resin restoration for number 30. He was referred to us from a denturist. We have denturists in Canada, well, in most of Canada. They do all the denture work. And we did implants, extractions, grafting, and 4 implants with locators. And then he went for an implant-supported denture. Patient on the right, we restored from start to finish, where it was full mouth rehab, where we were able to save, other than 2 teeth, all of his teeth. So where to start after deciding the need to open vertical? Because obviously in the patient that I showed you where we restored start to finish, you know, that with a worn dentition case, there was no choice but to open the vertical. So where's our starting point? Well, for those of you who've been through the academy or you're familiar with Pete and his teachings and our teachings, our starting point for treatment is always centric relation. Okay, this incredibly important position, that physiologic position, okay, where we're looking at the properly aligned condyle disassembly up in the fully seated position up against the eminentia. Has nothing to do with tooth position or vertical dimension. It's a joint position, and it's incredibly important because that lateral pterygoid muscle can release. Now, when we're looking at the occlusion, what we're looking for, if we can, ideally, if it's a patient, with all their teeth, we're not looking at implants in this case. We're looking for centric stops on all teeth with the shallowest possible anterior guidance. So we want dots in the back, lines in the front. Okay. So many articles showing what happens if anterior guidance is in play. One of the biggest articles we quote is the one. It was a groundbreaking article from Williamson and Lundquist, anterior guidance, its effect on temporal os and masseter muscles, and they show that the muscle activity in these muscles significantly decreased when anterior guidance was in play. We want non-interfering posterior teeth. Okay, so the back teeth, only contact during your closure, maximal intercuspation, and then you have immediate disclusion of the back teeth. Now, another thing that's very important for us, we want the anterior guidance, that inside-out movement, that grinding, whether it be parafunctional, chewing, that inside-out movement, to be in harmony with the M-mobile function, which is the diagram on the right, where that yellow zone is that zone where your mandible is moving during speech, chewing function, and we don't want any collisions happening. Okay, that's the key. We want anterior guidance to be at play, but we don't want it to get in the way of M-mobile function. We had a bad rap where there was an article that came out called The Myth of Anterior Guidance that was very critical of anterior guidance, saying basically that Pete was only focused on inside out, which is completely false. He was also focused on outside in. Okay, so we are looking at both. Now, second thing, we know centric relation is the most important thing we look at. Second most important thing we look at is incisal edge position. And determination of the correct incisal edge position, not just with the upper teeth, but with the lower anterior teeth, is the second most important decision that we make. And again, people who've been through our curriculum, we've beaten that to death with you. You've seen it in the hands-on courses. One big differentiating thing from us versus other academies is we don't just look at setting the upper anterior teeth, upper smile. We're really focused on that lower incisor edge. One of our former faculty members, Glenn DuPont, referred to it as the leading edge. It's so important. It's what drives the function. Variations in invulpal function is basically determined on how our teeth erupt naturally, how they're guided into their full eruption. You can see there's three very different envelopes of function from the left to the right. Right, it's very restricted where there's hardly any movement there. Very tight envelope of function. And where we set those incisal edges can make can affect things greatly. Patients on the left, if you were to move those incisal edges into that envelope of function, you can get chipping of those anterior restorations, which it's happened to me before. Whether it be a resin restoration or porcelain, and it was probably an interference to that envelope of function. Patient on the right, we move that incisal edge forward. Patient where everything's tucked back in, maybe a class 2 div 2 patient, and we move it forward too far. Now we could be affecting the neutral zone position of that teeth and really affecting lip closure, especially lip closure of that lower lip over the upper teeth. Now, when we're looking at the vertical dimension of occlusion, how is vertical dimension defined? It's basically defined very simply as a different distance between two anatomic points. On this diagram on the left, you can see, it's basically, nasion to the menton position of the chin. The occlusal vertical dimension is the vertical dimension when the teeth are in full maximal intercuspation. So when we're looking at vertical dimension of occlusion, what determines it? It's the repetitive contracted length of the elevator muscles. It's what determines the vertical dimension of occlusion. Okay, so that repetitive contracted length of especially your masseter muscles is what dictates that position. Now these are two diagrams. Okay, diagram on the left. Okay, is this patient's initial contact position and centric relation. And then diagram on the right is patient in full MI. There's now anterior centric relation. Now you'll see this in our hands-on courses. One of the big advantages of centric relation, it's this magical place really, because it offers us so much advantages. It offers us coordinated muscle function with which in a situation where you have a worn dentition case and we're dealing with muscle imbalance, excessive force, centric relation, and starting there, releasing that, inferior lateral pterygoid muscle, that position of muscle, and just creating coordinated muscle function is a huge advantage. Another big advantage you can see here is the bonus zone. Okay, so you can see in that initial contact position between the molars 2 and 31, there's a huge slide for this patient, and there's a gap there. So this is a patient, on the left where we may not have to do this huge, massive opening of the vertical. We can do a combination of, building up interiors to the edges that we want, and doing some reductive in the back so the teeth eventually line up, full maximal intercuspation with the joint in the central relation position. So what happens to vertical dimensional occlusion when teeth wear and when VDO is increased? This is a great diagram on from Pete's book. Okay, so one very interesting point. So if you're looking at B is a measurement from anatomic landmark to the occlusal surfaces of the upper and lower teeth. A is same anatomic landmark to the CEJs of these teeth. Patient on the left, regular dentition. Patient on the right, worn dentition. Here's the key point. Most of the times when people have worn dentition, they don't have a reduced vertical. Their VDO is the same in this worn dentition state as it was when their teeth weren't worn. What happens is, again, you have the teeth wearing, so the A position increases. Okay, so either the alveolus elongates, or the teeth are somewhat intruding. So this A position from anatomic landmark to CJ changes because of those 2 points, but the B measurements from the same anatomic landmark to the occluding surfaces stays the same. So that vertical dimension of occlusion, even though we've got wear happening, is basically stays the same. This is incredibly important This is a patient that we just finished, came in, was referred to us, pretty worn. We're talking erosive wear, attritional wear, bruxing, a lot of wear. So you'd look at this patient, you'd think, well, he's got a collapsed vertical. But that wasn't the case. I mean, this is from a study. We're looking at facial proportions for a patient in their face. You can see with this patient, this is a scrotum calipers. You can order this from Amazon, and one of the facial proportions is from the eye to lateral of his nose, his nostril, and then from that same nasal position to the menton. So it should almost be 2/3, 1/3. And it's exactly that. For this patient, you would think, worn dentition, possibly collapsed vertical. No. His facial proportions are exact. Now, like I said, what the vertical is determined by the repetitive contracted length of the masseter muscles. Now, changes in, when teeth are wearing, what's happening is, as described in these studies, is that either you're having the alveolar bone remodel or the teeth are intruding. Okay, so this is what is, what is proposed, and what is happening as this repetitive contracted length stays the same. What's happening there is it's either remodeling the bone or intrusion of the teeth. Now, this is a case, this is one of our patients. She had a pretty deep overbite. This is a patient we had to open vertical. Here's the good news. Multiple studies have shown that even though you open the vertical on a patient, the video can be stable, okay, without collapsing or a major intrusion. Possibly some remodeling of bone happened with this patient, but relatively stable. No damage to the teeth or changes in terms of intrusion. What multiple studies have shown is that the relapse to the original vertical dimension of occlusion was minimal. So here's a very key point: is how much can you open vertical? And the amount you can open vertical, what the studies show, intersizally, what can be tolerated is 5 millimeters. When you work through these cases, this is a case we worked on. We completed it last year. It's never really are you gonna have to open that pin beyond 5 millimeters. You can see over this patient, pretty worn case, to establish the tooth contours that we wanted, the occlusion that we wanted. We had to open up vertical just beyond 3 on that pin. You'll never have to open beyond 5. So that's, for all of you who are looking at these cases, that's some peace of mind that you'll have. Now, remember that 3-to-1 ratio, anterior posterior, when opening video. I did this slide, this year, and I recently saw somebody speak. I think that's changing now. I don't think it's exactly 3-to-1. What I mean by that is, what was thought was that if you open, say, the pin, or you open the bite 3 millimeters in the anterior, you're only having to open it at 1 millimeter in the posterior, because again, from what we know, from what we teach, and what the research is, jaws open in an arc of closure, right? So, there's much less opening needed in the back than the front. Now, I don't know if 3-to-1 is exactly accurate. I think it's actually less than that, but it's a guideline. So now we're going to get into the fun part. Again, if you put your questions, I'll answer everybody's questions at the end. We're going to get into the fun part. We're going to look into treatment planning and sequencing for a patient. I like to simplify things. This is why I came to Dawson. I love this quote: "Life is really simple, but we insist on making it complicated," from Confucius. We have 3 sons. They are 13, 11, and 7. And I'll be honest, thank God we're out of the toddler phase, because when we're in the toddler phase, this is my youngest, it was pure chaos. We were on a flight to Mexico. I don't know what we were thinking. Because trying to manage this guy for 4 hours was like, traveling with a drunk old man who speaks a foreign language. You just don't know how to rationalize with them, and you don't know how to help him. He's wearing, he looks like he's Tony Soprano in this outfit. He's wearing headphones. He's not listening to anything. Just chaos, pure chaos, and that's my poor wife. So this is the case we're looking at. It's a worn dentition case. Uh, this patient went to the denturist. I mean, basically, he was in a dental office, a good friend of mine. He was seeing my friend for treatment, and my friend just kept, saying, "No, you're fine," and really wasn't paying attention to where he was getting frustrated. He went to the denturist. He wanted to have all of his teeth taken out and have all four prostheses made. Thankfully, the denturist, sadly, she's passed on. Amazing clinician, and she understood occlusion, and she said, "There's not a chance I'm going to do this for you. Um, you get into all on X, you're going to mention these implants are going to fail because of the forces you have in your mouth. You need to go see PO." And he came to me, and we went through the whole process. We went through the whole records. We started off with an exam. Uh, when we looked at it, there were a couple of hopeless teeth. This is a patient I showed in an earlier slide when I showed the two photos of the patient with a lot of caries and the patient with worn teeth. This is that patient. He had a couple hopeless teeth that needed extractions. Okay, 3, 5, 15, 19. He wasn't going to have an implant for 18. And I was fine with that. I knew that, if I can establish the occlusion from second molar right to first molar left, we can get a great result. But the other teeth that we were taking out, 3, 5, and 19, we always had to do something there. You can see here, this is the teeth here that we were taking out, and then one at the bottom. Just hopeless situations, uh, caries, failed root canals. It's just not a good situation. Now, this is a smile wizard. Anybody who's been through curriculum, you know about this. Everything I do when I'm doing these workups always happens through the smile wizard. His joints are stable, which is pretty common with a lot of these worn dentition cases. The teeth are the weak link, and the joints and the muscles are fine, which is, it's amazing. They don't even have any muscle tenderness, none. Obviously, the main thing is the severe wear that was happening. I'm just going to go through a couple of the key 2D checks that we looked at. Lawrence axial plane, obviously you have a fair amount of wear. It's a concave plane, which is not great for function. We want to be either, ideally convex, slight rise from, that curve of speed situation, slight rise into that interior plane, or at least straight, but not concave. So we knew we had to do something there. These are the measurements we're looking at. This is my favorite slide when we start looking at the wear and we decide how much we want to add length. Where to set all the lengths. Are we gonna, do not just where we want to add lengths, but where are we gonna do any sort of, gingival surgery, whether it be grafting or aesthetic crown lengthening. His width to length ratio on his teeth, was 94%. It was basically a square tooth. And if we can shoot between 75 to 85% width to length ratio, that can really create a very beautiful, central incisor. This is the imaging part where we're looking, kind of the ideal, just a guideline of where we want the teeth outlines to be. Now, this is one key point. I don't know if we talk about this. We might actually mention this core one. But looking at the face form on molar bite force with a natural dentition. So we're looking at, different types of, a tapered face form, square form, there's different types of jaw shapes. And for this patient, he had the worst type of face form, that square face form, because the studies show that these patients exert a lot more force than those with, a non-square tapered face form. Now, timeline for treatment. when we're looking at surgery, surgery is a rate limiting step, I like to say. You know, where everything we do, we have to kind of stage it by getting that surgery out of the way. Uh, we just had a patient today. It's a full mouth, really worn dentition case. It was actually uh, the friend of the patient I'm showing right now, and he came to us because he's going through the same thing. We did implants for number, let's get my American numbers wrong, for number 7 and 9 today with grafting. I just put a temporary bridge to his existing dentition. We're going to let everything heal before we start loading his implants. We were also going to do crown lengthening for the bottom too. So timelines for surgery, crown lengthening in terms of when you want to proceed with your restorative phase, crown lengthening anywhere from 2 to 6 months. Implants, implants can be loaded immediately, which I've done, or you can wait even upwards of 10 months if you had to do a significant amount of grafting. Opening vertical, I mean, the research is it's varied. It's all over the map. Some people feel like you can go straight to opening vertical right away. A lot of us in the faculty like to have our patients test drive the provisionals for at least a couple months before we convert it to porcelain. Now, surgery is a rate limiting step. Okay, so one thing I remember from my undergraduate in chemistry, and it's always important to keep that in the back of your mind. We know starting point is central relation. So for this patient, what we were planning, we knew what we had to take out. From biologic stability standpoint, really was no caries. So the teeth that we had to take out with grafting and crown lengthening, and then the implants. Functional stability, opening vertical with temporaries, and then the final restorations. Now this is his wax up. Okay, the blueprints, everything was scanned, and we used the wax up obviously to make our temporaries. All of our stents were made up the wax ups, and we used the wax ups too to help dictate how we were going to place those implants. Our implants, most of the times, are guided when we do our implant placement, and we obviously want it to be prosthetically driven. Now these are the stents. We have the stents above the two models are the static functional crown lengthening stents. Stent on the bottom is the implant guides. One on the right's for the top, one on the left's for the bottom. Guide implant stent marking the gingiva. For those of you who place implants, guides are great, but you have to make sure you don't want to obliterate the attached gingiva, and I've done that because every guide has the opportunity for you to just punch out the gingiva, never raise a flap, just go in, do your drills, place the implant, and then either cover, score, or healing abutment. But I've been burned by doing that, and I didn't pay attention to the attached gingiva, and I took out the attached gingiva, and then we had major gingival issues because there was no attached gingiva protecting the implant. So mark this, that's a key point. We really didn't have to do really much aesthetic crown lengthening, and it was minimal, just flaplets on the top, but bottom was way more challenging. Okay, so we had Essex sweat stents from the wax up to mark gingiva for the crown lengthening. This is the aesthetic and functional crown lengthening that we did, very simple on the top. On the bottom, though, was way more challenging. It was challenging. It's not just aesthetic, which is much easier because you can keep your bone reduction on the facial. We had to go interproximal here because I really had to increase the ferrule for this patient. I had to, explore some most tooth structure because I can't reduce this occlusally. I want to be into pulp. So all I could do is smooth out those sharp edges so there's no pointed or sharp points in the tooth restorations for those crowns, which porcelain, emax, zirconia is not good. But I had to increase ferrule. Opening vertical, again, one key point: if we are opening vertical, we are moving the jaw in a class 2 direction down and back. So in a patient who's a class 3, almost end to end, opening vertical actually works on our favor because it's kind of moving them slightly almost into a class 1 relationship. Now, again, you're looking at here, we showed a study talking about opening vertical, it's pretty well tolerated. We know we don't want to open it more than 5 millimeters incisally. But people, when you've opened vertical, a lot of studies show that there may be some discomfort in the first 2 weeks, but usually then there's a resolution of symptoms. Again, as long as you're not going beyond 5, there's usually no clinical consequences. And good occlusal stability can happen from this. So now we're in the temporary phase. So we went through surgery. We had temporary crowns made for the implants. We're starting to prep and temporize everything. So we've got everything prepped. We're really happy where we're going. We've lessened that overbite. I love the photo on the bottom right, that not of the tent itself, but just that angle. We teach a tip down photo at Dawson. This is like a reverse tip down where you're standing behind the patient and taking that photo. And for me, I can really see how well teeth line up relative to the vermilion border. My sequencing, I like to insert it. I like to insert the lower restorations first. That's how I like to do it. So once I've got the temps made, I've established a bite. He was in his temps for about 3 months, very minimal to no chipping, maybe a couple small chips here and there. I know now, he's stable. He can tolerate this vertical, and now it's time to convert this into glass. So I like to restore everything on the bottom first. I know there's differences among faculty. Some faculty like to put in all the anteriors first and then restore the posteriors after. I'd rather restore the lower arch, which I consider the foundation for the house, and then restore the upper arch. So final restorations, top and bottom. We went from there. Really proud of this case. It was a challenging case, but what I'm proud about, it was not just aesthetics, it's functionally driven aesthetics. And we were able to, keep pretty much all of his teeth. So what he thought was a hopeless situation was actually, a situation where we were able to save his teeth and he's been like, his confidence is through the roof. It's just, I'm not a prosthodontist where I see these patients and then they're out the door and never see them. I mean, sometimes it is for referring offices, but for this patient, he's a part of our hygiene practice and he comes in and he's beaming. And it's just, that means more to me than anything else I can achieve in this profession. The tip down smile, again, from his tip down shots, big difference. You can't even see his teeth in the worn case, and now we've established a smile. Very important to note that when we're doing this function different aesthetics, you always want an index, and a lot of labs will forget to do this, even though you specify this. You always want an index of your approved provisional model. Okay, so we scanned his temps. We wanted a sizable plane. He's happy. So it's just about my lab technician, following what we did with the temps. This is my verification to make sure that they follow the temps. So this putty index. Tech scan, we teach this. Tech scan is amazing. This is for a different patient, but tech scan is a great way to check your centric. It's a great way to check your excursions. Making sure that you have that disclusion. It just helps you really see if you've got a good balance. Ideally you want on that lower, underneath that full arch, you can see left and right. Ideally you want it between 45 and 55%. Now, here's a key point. If one side's missing, remember with this patient, we weren't restoring the second molars on the left side. It's going to affect that force, right? So that you'll never get 50-50 there, because there's always going to be more force on the side where there's that extra, the other second molar. But we're really happy with the balance we got here. Light inclusion on the implants. Okay, we want light occlusion there. Tech scan's a great way to show that. Anterior guidance with centric stops on all the teeth with, light occlusion on the implants. So it's a slight modification to what we're talking about. Because of the wear that he had, we splinted 6 to 8 and 9 to 11. And with that, I mean, actually, this went through faster than I thought. Um, the vertical challenge, any attempt to open the VDO should be in centric lation position with a maximal inter-incisal opening of 5 millimeters. Implants versus teeth. Teeth are more adaptable and resistant to biological and occlusal forces, and they offer a first line of defense should failure occur. So we think of that restorative restoration failure domino effect, right? So, I teach on resins too, and I talk about the fact that, doing a really good MO or DO resin restoration really matters. If you don't like, I do a lot of fillings here. It's not like I do this all the time. And, if I don't execute my filling well, they could lead to leakage. That could lead eventually to root canals, then crown. But let's say if we have managed forces, that crown fails, they lose that tooth. Now all of a sudden we have less teeth. Other teeth are taking more force. Becomes this vicious cycle where you get to the point where now we're almost, in those worst case scenarios, we're looking at all next situation. But if there's a failure there, then what? I mean, you're now down to a last line of defense, and now you're into an edentulous situation, which is unfortunately can be very crippling for some patients. Treatment planning sequencing, you'll learn this if you haven't been through the academy. You're going to learn this big time. I mean, I think we're second to none at teaching about this. I think when it comes to sequencing and planning, I just don't see any. At the risk of sounding arrogant, I just don't see any competition to the Dawson Academy. I just think, the way we go through the steps is just going to be life-changing with how you do your treatment. We all have a preference. I like to finish a lower arch before proceeding with the upper arch. That's just how I like to do it. I just want the to finish the upper arch to be, the final that goes in, the final celebration, right? And that's when we're pretty much done. I do bring patients back for a couple appointments after everything's in for occlusal equilibration, just to fine tune the occlusion. But that's how I sequence it. With that, I love this quote. He who fails to plan is planning to fail, from Sir Winston Churchill. That went through faster. I had more slides. I thought this was going to take longer than I thought. You can reach me anytime at my email address or text me. My Instagram too. I do post cases to showcase what we do. I would highly recommend looking into if you haven't been through Dawson to start with Core 1, Occlusion and Smile Design. Lenny Hess, our clinical director, he's an incredible teacher, incredible lecturer. People who see Lenny are inspired by him, and they just love learning from him. He just is able to simplify these, sometimes tough concepts, and you'll be blown away if you see him speak. I learn from him every time I teach with him. And there's many dates coming up in 2025. They're already starting to fill up pretty fast, and we'd love to see you at one of those dates. And with that, we're going to start going through the questions.